Just start by making a very warm welcome to everyone to this seminar in our Centre for Care seminar online series. My name's Sue Yendall and I'm Professor of Sociology here at the University of Sheffield, and I'm the Director of the Centre for Care. And it's really a delight to be able to welcome Adelina Comas-Herrera to talk to us today about a really important project, the STRIDE project, which I'm sure she's going to tell us all about. But it's a project which is about responding to dementia in a range of countries around the world. And on one of the occasions over the past decade or so that I've met Adelina, we were in Kenya, and I was pleased to see that you're still working with people in that part of Africa, which is great. And as you know, through my role in the International Journal of Care and Caring, I'm very interested in the international dimensions of care and how much we can learn from each other. And I'm sure that this is one of the things that Adelina is going to talk about in her presentation today. Adelina is based at the Care Policy and Evaluation Centre at the London School of Economics, and she's Assistant Professorial Research Fellow there and has been for some years. And it's always a pleasure to hear her speak and to learn about what's been done at CPEC. And so without more ado, I'm going to hand over to you, Adelina, for you to make your contribution. Can those of you listening please think about any questions you might want to ask, any points you might want to raise or comments you want to make. You can put those into the chat, or you will be able to raise your hand in the discussion part of the seminar afterwards. So over to you, Adelina.
Thank you very much. And I'm really delighted to have been asked to contribute to this webinar series. I keep following it and catching up when I can. And it's really fantastic to see all the work coming from the Centre for Care and also the convening power that you have. And I was also very happy to visit Sheffield finally at the Transforming Care conference, and it's just very nice to bring a bit more. So we'll be covering a range of, so I'll start talking about STRIDE, which is the project that, in fact, when we met in Kenya, I think at that point we were actually drafting and trying to submit the application, and you'll hear all about it and you'll know what STRIDE stands for. But I will be also trying to reflect a little bit in some of the issues that we've experienced in relation to care during the pandemic, and also some of the responses that we're developing in a global context. So I'm going to have a lot of acknowledgements, but I really want to say that the presentation I will give draws on a huge amount of people's work, and many people who were also very deeply affected by the pandemic, and I really want to acknowledge them and all of those who lost their lives and all the people who suffered in the pandemic. So some of the work I'll present comes from the Strengthening Responses to Dementia project, which was funded by UKRI, some of it from another project called Social Care Recovery and Resilience, funded by the National Institute for Health and Care Research, but all the views I'll present are mine and not those of UKRI, NIHR, or any of my collaborators or research centers. And well, I probably don't need to tell you this, but demography is changing not only in high-income countries, it's changing all over the world. And many countries in low and middle-income countries that have until now been looking like young countries are also aging. And even in countries where they're not necessarily aging fast as a proportion of the population, the numbers of people who are older are growing just because the whole population is growing. And we basically have more and more people who are able to live longer, but also with conditions such as dementia, which means that we will be seeing an increase of need for care globally unless we become really, really good at risk reduction. But it's also important to reflect that even in the high-income countries, in the developed world, or whatever you want to call it, the minority world, we still have relatively few countries that have accessible, affordable, and high-quality long-term care to respond even to the current demand for care. And I think it's very important to start by acknowledging that and by seeing that improving care systems is something that almost every country in the world can definitely do better at. So I'm going to start a bit, and you will see I talk about long-term care, not about social care. So I will also explain a bit what I mean by long-term care and why I'm using this. And basing this on a definition that I like a lot from the World Health Organization on their World Report on Aging and Health from 2015, that defines long-term care as the activities carried out by others to ensure that people with or at risk of a significant ongoing loss of intrinsic capacity can maintain a level of functional ability consistent with their basic rights, fundamental freedoms, and human dignity. Now, there's a lot of jargon in here, but basically what I think is very interesting is that this definition is much broader than what we call social care in England. It includes quite a lot of health, including preventative aspects of healthcare that are very important, that we often don't think about in the context of care, but that have a huge importance in terms of ensuring that people can live their best lives and perhaps even postpone the moments at which they actually need support from others. And I think it's very important also that they emphasize the importance of care being consistent with their basic rights, fundamental freedoms, and human dignity. And in practice, the type of care I'll be talking about was I'm very interested on any type of care that can reduce, lessen the consequences of, or compensate for disability, cognitive impairment, and loneliness, improve quality of life, support family and other unpaid carers. And care, of course, can be delivered in people's own homes and on the community or in substitute care settings. And it's interesting that in many parts of the world, they use the long-term care term only to refer to nursing homes, when in practice, the majority of care is happening in people's own homes, usually provided through family. And on this, care is provided by unpaid carers, it's mostly family, but also other community members, neighbors sometimes also have a role, and formal care providers, which could be in the public, private, and voluntary sector. And this is a sector where we normally see low levels of training. And the types of activities can be everything from support with everyday tasks, like the traditional activities of daily living, but also it could be therapy, it could be social participation, and more preventative activities. And I'm saying all this, and I know probably all of you know this already, but I think it's important to know that we're talking about the same things, and to remember that there is a very broad range of activities and services involved in care. And I like a lot this, perhaps quite complex, but this diagram from the World Health Organization, WHO Europe, where they're trying to map out everything that's involved in long-term care and putting people at the center, and then looking out from the perspective of the long-term care system, but also understanding how it needs to coordinate and perhaps even be integrated with the healthcare system and social protection system, and how they all have a role, how there is a big overlap between these potential three systems, and how in practice it is very complex because we have a huge amount of aspects to bring together and that are affecting the individuals in the center. And just again, you probably know all this, but I think it's a useful reflection is to think of what is there before we have long-term care systems. And this is something that in the work that we did in the STRIDE project, that I'll talk a little about later, was very clear from looking at the existing long-term care system of the 7 middle-income countries we looked at. And what we find is that long-term care is provided almost entirely by families, not a surprise, of course, and others tend to step in when other care is not available in the cases of people who are usually both poor and have no family. Care is, of course, mostly provided by women. That also happens in the minority world. We also see quite an important role of community, neighborhood, and also religious organizations. So in Jamaica, for example, churches have a really important role, but also in other countries, other religions, different religious groups are really important in providing community support, and sometimes even taking people into some sort of residential care. We find that there's quite a lot of use of long-stay hospitals, geriatric wards, quite often for people who are also poor. So here is where there's this overlap between poverty and needs for care. We find that social services will often only be there for people who are destitute. And sometimes, and we're beginning to see that in quite a few low and middle income countries, there is actually support from community health. There isn't quite often any infrastructure for community, what we call social care, but there is a community health support quite often in the form of community health workers that are there and are part of an important infrastructure that I think it can be built on. And yeah, we do find even in middle income countries some very wealthy people who can access private care. A lot of these people will probably first port of call will be living domestic workers, but we're also beginning to see even in countries like Indonesia, quite a few, and in India, some dedicated residential care for wealthier people. And we did see in the pandemic that there were also other private residential care facilities, not on the luxury end, that are quite often unregulated and not really well understood in terms of being part of the long-term care system. Globally, we share some challenges all over the world, and it's important that also when we think about care, we think about everything that's around it. And we always talk a lot about we having large numbers of people living to older ages. We also have very strong evidence showing that another important factor of this aging is that people are living longer with complex health needs. And that all of this is happening at the same time where we're having fewer numbers of people of the traditional working age, and that is, of course, creating this huge problem with workforce that we're seeing coming to place all over the world at the moment. We have also seen, and we continue to see, changes in the roles of women and in the labor markets. We're seeing also changes in expectations about how we want to live as we grow older. And there is, perhaps not universally, but there is an expectation that the public sector would have a role in helping us insure against the risk of needing care, especially if it's for long periods of time, and especially because this is due to ill health. And in countries where there is a health system, and when we have a well-developed health financing that is universal and in principle would cover us for anything to do with their health, it often comes as a surprise that when you need long-term care, that's quite often not included or not covered in the same way. To try and understand all this, the World Health Organization has been working on a way to support countries in strengthening and improving their long-term care systems. And they make this distinction in building on their previous work on building blocks of healthcare systems adapted to long-term care. And they identify the importance of having a good governance structure in place, care system, sustainable finance, having information monitoring and evaluation systems in place, having a workforce strategy and investment in workforce. And then, of course, with all these, you're able to deliver services and have a service infrastructure. And they also emphasize the importance of innovation and research to inform the development of the systems. And of course, all countries have something in terms of care. Quite often when you're especially speaking to people, researchers in low and middle income countries, the initial discussion we have, they will say, oh, we don't have a long-term care system. But then, of course, if you start looking, there are some aspects in place from all of this. Maybe it's on reaching a really, really small part of the population, those who have very few resources and who don't have family care. But we do have, for example, a workforce. This is their unpaid care workforce, and we do have services being provided. That's all the care that's provided at home. So in all the countries, some of these elements are there. Just in most countries, we still have a lot of room for improvement. We also see historically that when countries develop their care systems, they start from their existing health and social care protection system. So you have quite often many countries that don't simply expand what they were providing in terms of tax-funded public health and also social protection to also cover the care needs resulting from chronic conditions. And that was the approach of the Scandinavian countries, but also we see Thailand has adopted this approach as well. Instead of going for long-term insurance, long-term care social insurance, they've gone for expanding what they cover through taxes. In other countries where there is a well-established public healthcare insurance, then what you see is that this is expanded to include long-term care, like the Netherlands did, or they create a parallel public insurance system, as is the case for Germany, Japan, Republic of Korea, and now also China is doing many pilots on this, and it's very interesting to see all the development. And as I mentioned before, in many low and middle income countries, what we're seeing is also some interesting examples of how community health workers are being trained to support people with long-term care needs and unpaid carers, which basically is suggesting to us that what seems to be happening is that there's a bit of an expansion of what's provided, especially in primary care, through the healthcare system that is including more support for long-term care before they even consider developing a separate social care system. And it'll be interesting to observe how that develops. As I have said now a few times, even in high-income countries, many long-term care systems are still working in progress. And when the pandemic started, I don't think we had much change from this quote from the OECD, from their Health Wanted report in 2011, where they say that there's a history of many countries having long-term care policies being developed in a piecemeal manner, responding to immediate political or financial problems, rather than being constructed in a sustainable, transparent manner. The future of long-term care is more demand, more spending, more workers. Facing up to this challenge requires a comprehensive vision of long-term care. Muddling through is not enough. And I think what I'm going to ask you to take on from this is that perhaps this sounds almost painfully familiar, and definitely to the UK context. And I think it's very important to think about this sentence of a comprehensive vision of long-term care. And I think it is quite difficult to have this comprehensive vision. And what I'm going to talk about next, though it might seem a bit unrelated, you will see that it comes to understanding what this comprehensive vision might be. So, as I said, I'll move to something that may sound a bit different, but then this was almost accidental for me as a researcher. But when, so a few years ago, we came, so I'm going to go back, we applied for funding to work on strengthening responses to dementia in 7 middle-income countries. And one of our partners was from the University of Cape Town, and they were suggesting that we could use theory of change to understand what we needed to do in each of the different countries we were working on to do the best or the most appropriate or the most helpful research, given where they were at in terms of the developing of, in this case, dementia care. And so they brought in theory of change as a method, and this was new to me, and it was a very interesting experience. And I don't know if you're familiar with it. I like to always, when I talk about theory of change, start with this slide, which is basically, a treasure map, and we are in this ship, and we want to get to the treasure, and there seems to be a path. And with theory of change, what we do is we take stock of where we're at, we take stock of where we want to go, and then we basically map a way to get there. And that's basically what I have understood theory of change to be. There are also other ways of doing this, but I found it very helpful. And I understand that theory of change was developed initially for many projects that were being funded for economic development, and it was to support reporting and accountability and provide a framework for research evaluation. And in this case, although we started with trying to almost develop an intervention in the sense that we were developing a research agenda, what we ended up discovering is that it was a very useful tool for strategic direction. And one of the great things about theory of change is that if you bring together a group of people with lots of different expertise, you're able to interrogate lots of different aspects of this path of getting to something better. And you're able to examine this maybe more obscure parts of the system through which you achieve change, where perhaps some of us don't have the expertise and might look like a miracle needs to happen, but others might be able to bring their perspective and help us understand how to go from one step to the other. And so here is some photos of the STRIDE project. And as Sue was saying in the introduction, we did have some challenges because the pandemic caught us halfway through. The project happened in Brazil, in Indonesia, India, Mexico, Kenya, Jamaica, and South Africa, with the UK as a partner. There's a photo here of our first meeting in London at the LSE. There's another photo of our second meeting in South Africa. And then from then on, everything had to be online with many challenges. I mean, imagine trying to do online meetings when in South Africa they were having power cuts. And we also were about to go and do our field work just when the pandemic started. And so we had to halt everything. We were able to do some of the field work later, but towards the end of the project, the last 8 months, the funder decided to cut the funding because the UK wanted to reduce their spending on overseas development aid, and our project was classed as overseas development aid. And as a researcher, that was the most stressful situation in my life, and it was really embarrassing to have to tell people in the 7 countries that we were very sorry, but the funding was being cut and we had to reduce our activities. And basically we're still working on our spare time on trying to finish some of the work from the project. We have a project website where you can catch up a little bit. And in terms of what we were aiming to do was to generate policy relevant evidence to support the development of policies to respond to dementia. It's very much what we call formative research at the early stages on trying to figure out what it was the countries needed to be able to think about developing dementia policies. As I said, we use theory of change. This is a photo of the first one we did in London. And we did it I think this is in Indonesia. Yes, we did it in Mexico, in Kenya, in India, in Brazil, in South Africa, and Jamaica. In every country, it was very different, and we have a report on each of them on our website, but it was extremely, extremely enlightening in terms of helping us understand what were the key issues that needed to be addressed and what type of research would be helpful in that particular country at that particular point in time. And something that we did for the whole project was this theory of change. And here, this is a very summarized version because we did one for every country, and then we used everything from every country then to do our whole one for the whole project, and we've condensed it a lot to be able to even show it. And to the left, what you can see on the pale bit is what the STRIDE program could do to support the development of dementia policies in the 7 countries. And we identified how our different work packages would map onto the different aspects of policy change that needed to happen, and to understand how each of our activities could play a role. And what I wanted to highlight to you is that basically here what you have is a map that comes from the expertise of everybody involved in terms of what is the process of policy and changes that need to happen in order to get to a situation where in each of the countries, people with dementia and their carers live well, and their families do not shoulder excessive costs, risk impoverishment or health problems. And you can see that here at the bottom, almost at the beginning of everything, we have that there is improved public awareness of dementia, reduced stigma, and active inclusion of people living with dementia. Only if this happens, then people with dementia, their carers can be properly recognized, valued, informed, empowered, and enabled. And this was seen as a really important step towards improving awareness and perhaps generating more support for dementia as a policy priority. And of course, there was also thinking that it was important also to engage public and private funders and donors to also influence leadership and political will to then move us on to having cross-party legislation in place, and from that development to a dementia plan that ideally be funded and implemented. And then, of course, you also, dementia policy on itself doesn't do anything if you don't have a health and social care system in place that's coordinated and that is functioning well. And with you need all of that in place to be able to really then have the workforce that can provide this care and support, and only then you are able to make sure that people have the care and support that they need, and that personal care is delivered. And that was a very interesting exercise. And what I have found is that this is not that different than what we need to do in high-income countries as well. And I want to mention that one of the consequences of this work is that we took stigma on as a really important part of the Stride project. It was really, really important, particularly that community health workers understood stigma and primary care. And we developed, well, our colleagues developed interventions in Brazil and Kenya that they're going to present on a webinar we're doing on the 11th of April. I'll mention that later. And we also developed, my colleague Sarah Evans-Lasko led this work, a dementia reduction toolkit, an anti-stigma toolkit, with lots of people with lived experience of dementia talking. And in many countries, it's the first time that people with dementia have seen speaking publicly about their experiences. It's something that in the UK we're very familiar with, but it really is quite new in other parts of the world. And I'd like to mention that Alzheimer's Disease International were a partner in the project, and they have also taken dementia stigma very seriously. And we're conducting a survey with them that was already done in 2019 in the World Alzheimer Report 2019. We're now doing it again with a 5-year follow-up, and it's still online. And we're very grateful for anyone who helps us spread the word and wants to fill it. It's a survey that you can answer either as a person with dementia, as a carer, as a family carer, as a professional carer, or as a member of the public. And yeah, we'd be very grateful for any spreading of the word on this. And I've added here some resources on how we use theory of change in the Stride project, and we're very happy to share the slides as well. So, as I said, we had used theory of change in Stride, and then we also thought it was a very useful way of looking at what needed to happen in England as well. And this is part of a project that we're finishing to write up now, called Social Care Recovery and Resilience in England. And we also mapped the path that we need to follow. Now, this is a bit too detailed for you to see, but this was almost like a double theory of change, because we had the whole section about how to help the sector, long-term care sector, kind of cope with COVID. I mean, it's now becoming old news, but it's still there. And what's very interesting is how there were quite a few successful innovations and good practice and learning that was felt that could be brought to bear to an improved understanding of the situation in England. What's again very important, and of course there may be some bias here because those of us, at least 2 of us working here, had worked on Stride, is that what came up in this theory of change is not that different than what came in the ones I showed you for dementia, and I'll show you perhaps an easier to read version. And basically the game plan seems to be is that somehow we need to magic political will for reform that will lead to a new national care settlement, because there's so many things that are wrong that other participants felt that you really needed a rethink of the care system. And that involved a big rethink of governance, of funding and the creation of data systems. And as I said, this was also done near the pandemic, and that throughout it was extremely important to have inclusion and voice of people who use care and provide unpaid care. There was a lot of emphasis on joined up health and social care leadership and planning capacities. And it was a very, very clearly understood as well that you cannot really have a workforce strategy on its own without addressing funding, because unless you address funding, you can't really have good working conditions for staff, and that's a necessary condition to have sustainable, motivated, trained workforce. You also need the funding to modernize the infrastructure, and you need all of these aspects to come together to be able to have a social care system that's effective, resilient, can withstand aging itself, and economic crisis, pandemics, and climate shocks. And only then we're able to make sure that people who need care receive high quality care. And we worked with the participants on what would be good impacts. And here is about recovery from the pandemic, maintaining autonomy, people being enabled to live independent and fulfilling lives on one side, and on the other, that the people who provide care, unpaid and paid, can recover, have good, decent work, leading to better quality of life and well-being. So you can see it all coming together. And what I think to us become very clear is when you think of, so how do we go about improving a care system, is this necessity of a wholesale system rethink and reform. And this is, of course, difficult politically. And I think it is, we are missing something here in terms of how do we get there. And some reflection on this, we have also done, by the way, a similar theory of change exercise in Austria and in Spain. It actually looks quite similar. Again, there could be some bias because I've been involved in both processes, but the stakeholders do seem to think that there is an issue on how to make care seen as a both winner. And it seems that in some countries, perhaps in Denmark, where there is increased voice of older people and people who use care, perhaps there is more political pressure towards doing better in care and spending more on care. And it could be that some of the work that needs to happen is to do with increased public understanding about care and the implications of funding it or not funding it, and reduction of stigma. And this is, of course, very interesting. Many of you have been following the new Alzheimer's Society campaign on dementia, and it is a really important issue, how we depict care and how we depict what can be achieved through it. And it's very important how we get voices heard. And I think we may need to focus a bit more on this green bubble, because I think we already know quite a lot about how to do all the other parts of improving the care system. So a bit of, and here I'm going to tell you a little bit more about some of the work I've started now, is that the care systems didn't do very well. Well, this is just the biggest understanding. The care systems did really badly during the COVID pandemic. They really let people down. And we have been looking internationally through the LTC COVID initiative, and we did a report for the World Health Organization. And what seemed to be in common almost globally was that in most countries, not all, but most countries, long-term care was a low political priority, and that meant that the response focused directly into healthcare and other policy areas, that the fragmentation of the systems, the split of responsibilities, meant that at the beginning of the pandemic in most countries, no one was in charge. Failures in health and long-term care coordination meant that in many cases people who lived particularly in care homes, but also with care needs living in their own homes, had limited access to healthcare. Quite often there was active cases of discrimination. We saw that there was a problem with very weak regulatory oversight and inexistent or underdeveloped information systems. Many countries could not locate unpaid care systems to provide them support, unpaid carers to provide them support. We also saw a lack of recognition of the human rights of people living in care homes, the under-recognition of care staff created additional problems in the pandemic. The fact that, for example, they were not entitled to sick leave meant that they had to choose between having enough money to live on or put people in danger if they had been exposed to the virus and they might potentially infect people around them. And we did see also that many buildings that we're using as care facilities are not good enough, and that there wasn't in many countries a good enough community-based infrastructure to support people living at home. So this is all very bleak. But we also saw some positives, increased public and political awareness about long-term care. And for example, at the European Union level, there is now a national care strategy, and quite a few countries are acting on that. That may not be the case in other countries, but at least in some countries, we see some signs that this has been taken seriously. We've seen improvements in data and information systems, good examples of how well-established care coordination mechanisms work. So where there were good things in place that actually made a difference. We saw that some of the more innovative care approaches also seem to work well, like smaller care homes with more like home-like facilities, perhaps your own apartment. We saw increased use of technology, increased research focus on long-term care, and I think this is serving us well to learn from beyond COVID. And we did see a lot of international lesson sharing, and that was where I was most involved. And some of you may be aware of the ltccovid.org website we created on the 20th of March to share information about what was happening in the pandemic in real time. And basically what was happening is that nobody knew how many people were dying in care homes at the beginning of the pandemic, because only deaths in hospitals were recorded. But we were able to trace from even before COVID deaths started to be an issue in the UK, already in Italy, Spain, and Belgium, France, we were able to trace some data and also some newspaper reports that were very comprehensive. And we were able to start sharing it and to start raising awareness. And we were then we did the first ever report bringing together international data on how many people were dying in care homes. All of these headlines come from our study, also and that was picked up by WHO in a statement on the 23rd of April. And this basically showed that there was a vacuum in the international governance around long-term care. So because WHO only speaks to ministries of health, for example, and nobody was actually really able to monitor what was happening in care homes. We have to think that in most countries, long-term care is the responsibility of social affairs or other government departments, not of ministries of health. Therefore, there wasn't a direct link for WHO to even find out what was happening. So as a group of researchers internationally, we were able to do that. And of course, that was quite something that we felt we should build on. We continued to work through the pandemic. We did a couple of reports for the World Health Organization, as well as many articles. We had 37 country reports. The website almost had 500,000 views. We did more than 30 webinars, and there was a big virtual conference. Now, what was clear was that there was from all these, there was an agenda for change that was emerging. This what we call structural weaknesses in long-term care systems are there in most countries around the world. And the idea now is we've developed a new thing, the Global Observatory of Long-Term Care, that aims to be a platform for cross-national learning to improve and strengthen care systems. It's part of the International Long-Term Care Policy Network, but it's very happy to work with any other networks and groups. And the idea is to identify these key shared challenges, showcase how countries are responding, share research evidence, and facilitate collaborations. And everyone is welcome. Policymakers, industry advocates, care professionals, although the vast majority of members so far are academics. And this is actually now an invitation. So how to engage with the Global Observatory of Long-Term Care. The website is goltc.org, and you go there, you'll see that it's all organized around key topics on long-term care, tools and methods, that's more for the researchers, and on geography. And we have country profiles, we already have quite a few, and we are also functioning on the basis of interest groups. And the interest groups are really the motor of our activities. And if you want to take part, all you need to do is go to the experts directory page, and there's a button that says add your profile. You can enter your details, and then you're automatically a member once we check that you're a real person. And from here, you can share your knowledge through the details you put in your bio. But what you can also do, that's the most interesting part, is to create or join an interest group. If you want to create an interest group, you need to contact me. If you want to join an existing one, you can just click it. And we for now, are doing lots of webinars, but we're also thinking, and we're very happy to speak to others and have ideas about how we can use this, what is now basically an online platform, at global level, to share our learning on care. And yeah, we've got also the webinars of the videos, so you can catch up with what we have done recently. And I'd like to mention that our next webinar is on the 5th of April on social protection in Southern Africa. And then we have another one on dementia stigma on the 11th of April. And that's my presentation for now. And be very happy to have any questions, or especially any